Okay, well, I would love to welcome Katie to the podcast. Hi, Katie.
Good morning.
Good morning. Today we are talking about rehabilitation or rehab at a skilled level. And Katie has been working in this field for ever, a really long time, and is the perfect resource to help us get some questions answered. So we will dive right in. I'm so happy that you are here. And what is rehab? Let's start there.
Sure. Rehab is, under a skilled Medicare benefit, usually after so your loved one is in the hospital, and they're saying, well, they're not quite back to baseline, and we feel like where we recommend that maybe they need some rehab in order to get stronger, in order to try to go back home or whatever that previous living environment looks like, back to get back to their baseline. So, in a nutshell, that's kind of what rehab looks like. Individuals will come to us. They'll receive physical therapy and occupational therapy and sometimes speech therapy
Mhm.
to try to meet those goals, to work on strength, endurance, those activities of daily living, they say. So that'd be like dressing, grooming, bathing, feeding. And then if your loved one needs a like speech component, that could be anywhere from they're having swallowing difficulties to even maybe some cognitive concerns that they maybe noticed in the hospital or maybe that you're noticing. And speech therapy can work on those things as well.
That's awesome. That's a lot. Like
Yes.
there's a lot that can go into. So it sounds like people, when they come, it's not that they come for one specific thing, that there are maybe multiple disciplines that are going to be seeing the person.
Absolutely.
Okay. And how do they get to you? How do they
So,
qualify to come to you?
yeah. So, Medicare guidelines state that somebody needs to be in the hospital for 3 midnights in order to qualify for skilled nursing. And we're, of course, talking about the population usually 65 and older that are on Medicare. So, they're going to use that skilled Medicare benefit, but they need to have that 3 night hospitalization in order to qualify for that. And then it could be a combination. I mean, we receive referrals from hospital settings, assisted living settings, even, individuals that are potentially at home,
Mhm.
that, the payer source may be different in all of those, just pending if they've had that 3 night hospitalization or not. And we have a nurse liaison that will take those referrals and kind of knows what the criteria is for skilled nursing, for rehab, then and answer all those other logistical questions in regards to finances and have they met their 3 night qualifying stay and those sorts of things.
So it sounds like even somebody who is at home and maybe has not been operating at their strongest could potentially qualify, but how would they? Because it makes sense to me that the hospital and nurse liaison would be connected. How would someone at home figure that out?
Sure. If they have questions in regards to that, I always say, maybe start with your physician first, and say, this is kind of what's happening. Do you feel like a rehab stay might be beneficial? And if the physician says yes, I always say, you should reach out to a skilled nursing community
Mhm.
that provides rehab and ask those questions. They'll look at has that loved one been in the hospital maybe in the last 30 days? They could potentially at that point then qualify to come under their skilled benefit or their Medicare benefit. And if not, then doesn't mean that they can't admit to a rehab setting. It may just be more of a self-pay situation in order to do that. So
That totally makes sense. I remember giving a tour to a gentleman once, and he said, I feel like my dad needs a nursing home. He's at home. And I said, oh, tell me more about what's going on. And he said, well, like a week ago, he was up and walking around and feeding himself. And like now he's pretty lethargic and not really eating and really just staying in bed. And I was like, oh, wait a minute. Like, which
Things
we're
changed.
that's yeah, right. Which we're talking about rehab, not a nursing home in this conversation. But it was that start with your primary doctor piece
Yeah,
that made me think of that. Like if someone is at home and they're declining and you feel like, oh, maybe they need rehab, definitely start with their primary
primary
doctor
care.
and share what's going on because they maybe have an acute medical situation that needs attention.
Absolutely.
Yeah. So I mean, are people like being exercising like all day long in rehab? Like how often or how many hours a day?
Sure. We usually, Medicare will historically cover about if they need each discipline, it would be, like up to an hour of physical therapy, up to an hour of occupational therapy, and up to an hour of physical therapy 5 days a week. So they could be getting potentially almost 3 hours of therapy a day.
Okay.
Depending on, they always do an assessment when somebody is first admitted, the therapy team, and they will kind of determine from that standpoint how many minutes or how many, you know, how long that those therapy sessions are going to be. As somebody that comes in who's very deconditioned and potentially, has a lot of medical things going on, and they're not, their endurance isn't, at that capacity yet, they're going to adjust accordingly to try to get the, and we'll work with them as much as they can. So,
So it sounds like if someone is pretty incapacitated that they can start low and then kind of work their way up.
correct. Yep.
Yeah.
Yep. Absolutely.
Can people have visitors?
Absolutely. Yes. We encourage visitors, family to visit. And usually we will, after they've been assessed by therapy, they try to kind of get a schedule in place. So then you can tell other family and friends, okay, they're going to have, therapy on these days at these times. And then, so you can, when you do visit, your friend or family member isn't in their therapy session, so they can get full benefit from that and then visit on outside of therapy.
Perfect. And then what are people doing in between therapy? Like, are they just hanging out or what's
Yeah.
happening?
Of course, we offer, 3 meals a day, and then as well, we have activities, and it just kind of is up to the individual if they're very social and they want to attend those activities. We highly encourage that. Sometimes, it's therapy wears them out, and so they just want to rest in between therapy sessions. So we have lots of different options to meet those individual needs.
Great. What about how many days does someone stay in rehab or what's kind of the typical
Sure.
anticipated?
So Medicare will cover up to 100 days of rehab. However, that doesn't mean you're all automatically granted those 100 days. Medicare looks at a week by week basis, and we have to show considerable progress and gains in strengthening and endurance and functioning from a week to week basis.
Mm.
So I always say, somebody who may have 100 days of skilled rehab that might qualify for that might be somebody who's had a severe stroke, and it just takes a long time to regain those abilities. Whereas if you have a fall with a fracture,
Mhm.
maybe you're only looking at, 2 to 3 weeks, just depending on how you do from that standpoint.
So those are two great examples of why people would potentially go to rehab. What are some other scenarios or conditions that maybe someone has that would warrant some rehab?
Sure. If somebody has a heart condition or is hospitalized for a heart condition or COPD, pulmonary issues. We see individuals who have It's a slew of lots of things, but a lot of them are based off if weakness, a decrease in mobility or ability to walk and function, and that could be related to lots of different things. Some people come for if they're on antibiotic therapy and need
Mm.
IV antibiotics several times a day. Um, that's a considered a daily skilled need. Um, so it's there's a very wide range.
So that's a great thing that just came to mind based on what you said was like how much nursing type help are people also receiving? And because it sounds like a lot of exercise therapy and things like that. What kind of nursing type help are people getting?
Sure. The IV therapy would be one. Wound care management might be another. If somebody has to have like a wound vac, or that daily skilled wound treatment for
Mhm.
an incision that's not healing correctly, or vascular issues that may come up that somebody needs that from that standpoint. So
That makes sense. That's a lot of stuff that I would not feel comfortable doing at home for
sure,
someone that I am not trained for.
absolutely.
Are people allowed to like leave the building if they're there for rehab? Can they go out to lunch or spend the night someplace?
Sure. We have to be a little careful of that, because if Medicare feels, that somebody is able to go home with a loved one and spend the night or be out for extended stay, that Medicare may view that as okay. If they're able to do that, then they really don't need a skilled nursing community. Absolutely, people can go out, and have lunch, but it's usually those shorter, visits outside of the building, doctor's appointments, maybe, grab lunch after a doctor appointment if your family member takes you, and then returning to the building where you can receive that nursing and therapy level of care.
Yeah. My dogs are wrestling around under my desk. I don't know if you can hear
I can't
that.
hear them.
Okay, good. I'm like, get comfortable already. Oh, now she's shaking. I think really dogs are good therapy too. Can pets come to rehab? That's a good
Absolutely,
question.
absolutely. Yep, your pets can come and visit.
Oh, that's
Yeah,
so
and
great.
yep, we do have, our life enrichment department does have, pets that come on a routine basis as well, so,
Oh, that's so great. It's like holistic,
yes.
a real holistic approach. Um, I was thinking about how when I had a family member and the hospital came in and did this assessment because we felt like, well, she can't go back and we're trying to figure out what's next. It was determined she was not a good candidate for rehab initially, but then towards the end of the week, she saw improvement. Do you feel like it's a good idea for I mean, this is what I did. So whether you think it was a good idea or not, I don't know, but I pushed for them to reevaluate her towards the end of the week after she had had additional antibiotic treatment and things like that. So I guess
Absolutely.
just trying to figure out like when is the hospital determining that they would maybe qualify and bridging that gap with the building.
Absolutely. Always asking that question too as a family member,
Mhm.
because that is a, Medicare benefit that can be utilized. So if there's ever any questions from that standpoint, I would always ask, the at the hospital, ask the nurse, the physician, the social worker there, if that is something that they think would be beneficial for their loved one. And, be honest and be like, I see what they're doing here in the hospital, and I just don't feel like they're back to where they were
Mhm.
before this hospitalization. And I worry, you can say my loved one lives alone, they're responsible for cooking their meals and doing their laundry, and getting, potentially even, taking care of all of their daily needs of dressing and grooming and bathing. And if that is the case, then and they're not able to do that potentially, now
Mhm.
rehab is always a possibility.
The other thing that's coming up is I'm thinking about if it's a couple situation, like a husband wife scenario, and they're both in those later years of 60, 70, 80, 90, and one of them is trying to take care of the other person, but they themselves, their own health is being compromised. I guess, I don't know, just any thoughts on how to help them feel empowered that they can say to the hospital, listen, I can't do this. I can't do this.
Absolutely. And we encourage that. The last thing that we we want a spouse to do is, if something were to happen, if somebody were to fall and you're caring for that loved one and you both get hurt. So, using those resources, asking for those, outside assistance, as well, to try to keep you both as independent as possible. Because the last thing you'd want is for, both of you to fall and both have fractures, or, that would be awful. So,
Would be awful. How does it get determined when it's time for someone to discharge from rehab? Like, how do you know when it's time?
yeah, we lean a lot, of course, on therapy and nursing. Just have they met those goals? As the therapist initially will ask those questions. How did home look like before? What were you able to do? That's how they kind of build their plan of care in regards to what they need to work on. And when somebody gets closer to meeting those goals, then of course, the discharge planner or social worker gets involved, and we kind of start talking about going home and what that looks like. Therapy will usually say, I feel like they're going to be ready to discharge in 2 weeks. They may or may want to do like a home safety assessment where they go out to the house and kind of look
Mm,
it over and see if there's any needed equipment, or changing things in the home to make it more accessible, for that individual to go home. We can set up, other resources, home health care for some ongoing physical therapy and occupational therapy at home. It's going
mm.
to be, not as intense as what they've received in rehab, but therapy can continue to follow them, after they leave a facility and then discharge home as well. And then, of
Okay.
course, if the therapy feels like somebody's not meeting their goals and those goals are, not going to be met in a rehab setting, then we have those tougher conversations as well of, looking at, is going home appropriate,
Mhm.
um, from that standpoint. So
Which it seems like it would be so, and I know it is from my own experience, it's so beneficial to have a third party in the room to initiate and facilitate those conversations because as family members, we get very attached to our relationships with people.
absolutely.
And it's really hard to look at your parent or your spouse and say, it's not going to work for you to come home.
Right, absolutely. And we can help bridge that gap and give that news, and then, you can be part of the planning of that with your loved one. And, the rehab facility can be the one that kind of gives them, that bad news per se,
Mhm.
if they're not able to.
And it seems like you are very well resourced to know what is available in the area to at least move them in a direction, like
Absolutely.
about
Yeah,
resources at
there
home
are
or
lots of resources, anywhere from Meals on Wheels to hiring caregivers to come into the home. The a lot of individuals, will definitely be willing to have the home health care therapy, because that is covered by Medicare, whereas, hiring help is not necessarily covered by it unless you have like a long-term care policy, those sorts of things. So yes, we can help guide families in what that looks like and what's available, from, lots of different resources. Everybody has their own individual needs. It might be that this person lives alone and they might need an emergency pendant. So if they fall, they can hit their pendant and call,
Mm.
emergency to clear up to needing somebody to be with them 24/7 and having, hired caregivers around the clock. So we can, um, the whole spectrum, we can kind of assist with that.
Oh, great. Because people don't know what they don't know. And it's hard to know where to get going, where to find people. So it sounds like you're amazing in helping them with that. Can people come back to the building, to a rehab building for additional therapy? Like,
Absolutely. You can do outpatient therapy. So after you've, discharged from your rehab stay, a lot of buildings do offer outpatient therapy, or there's, in your communities, there's probably a slew of other, outpatient therapy, physical therapies that, you could go to as well. That just usually takes a doctor's order to attend that, and then, transportation and to and from. That's for individuals who want to be a little bit more out and about in the community, and don't have to be. If you do have therapy come to the house, you need to be in a homebound status. That's how your Medicare benefit covers that.
okay.
So, leaving the home for like doctor's appointments, I think they usually allow going to church and sometimes getting your hair cut, but that's about it.
Wow.
Don't ask me why those are the things that they've chosen. But if you don't want to be in that homebound status, and if you're able, to go out and about and eat with your friends and family, maybe go to the grocery store with a little bit of assistance, then outpatient therapy is an excellent thing to look into, because then you don't have those restrictions.
Okay. So I'm wondering if how much dementia is playing into people's ability to receive rehab or participate in it. Like if someone, because I'm aware, of course, that there are varying stages of a disease process and a dementia journey. Just I'm wondering if we can speak to if someone has a cognitive impairment or some dementia, would that prohibit them from receiving or doing any kind of rehab?
It doesn't prohibit, but it does add, another layer onto the rehab potential sometimes. Individuals who have dementia, sometimes that new learning, we're teaching them or trying to teach them how to do things a little bit differently from their norm, in order to potentially keep them safe. It
Mm,
could be, even using a walker that they're not used to using, or some other sort of assistive device. And sometimes that new learning is difficult for individuals with dementia. So it does kind of, it depends on how advanced the dementia is.
mhm.
But yes, that can definitely play a role in that progression of progress of getting stronger and getting back to baseline. Sometimes if there's somebody with dementia and then they have a fall, sometimes physically they can get back to where they were, but maybe they've had a decline again because that's a traumatic event. And they may have had then a decline in their cognition, unfortunately. So
Okay.
doesn't mean it can't happen, but it is something that needs to be assessed for, to ensure that that individual can regain not only their physical abilities, but their cognition in regards to safety and safety awareness. And that can sometimes be, it can become a little bit more complicated
Mhm.
if they can't. So
Well, and I'm thinking that even if somebody, and again, it's just so nuanced. I just really want to encourage people to touch base again with their doctors, the hospital social workers, the hospital therapy, physical therapy, occupational therapy people, just to get their determination if it would be a good fit. Because even if I can't remember why I'm doing an exercise, you're physically getting a little bit stronger each time you're participating in it. So,
sure.
some
Yes.
progress
Yep.
is still being made. but just really going back to leaning on those professionals to help
Absolutely.
figure that out. Um, so transitioning just a little bit, what are your thoughts around mindset and rehab? I remember talking to an OT once and they said it makes a difference because if you come to rehab and don't do the work, then it just doesn't really work. So just any thoughts on that, like around mindset and approaching it?
Absolutely. Mindset is huge. That motivational factor of, do you, will we, sometimes the residents will, or the individuals, they want to get stronger. And of course, they don't have everything they need to know how. That's where we come in. We'll give the exercises and those sorts of things. And so that being motivated and wanting to um, um, progress and to get stronger is huge.
Right.
And yes, I think there are some individuals out there that they may not have that motivation and need to try to figure out why. And maybe they're just we'll hear sometimes, I'm just tired,
Mm,
and I don't necessarily want to do this anymore. And I think that's really hard for families to hear because, from a family's perspective, um, they probably feel like their loved one is just giving up. Um,
mm,
but that is an opportunity. And I, would recommend that if you hear your loved one say that, you need to take that opportunity and ask more questions. Because we definitely need to remember that this is, their life, and what do they want? And I know those are very tough conversations, but um, those are key words and key things that really I encourage family members to talk to their loved ones about. Like, what else is going on? Why are you not saying that? Or why aren't you wanting to work with therapy and get stronger? And why are
mhm.
you, saying those kinds of things?
That's so good. That's so invaluable. And I really hope that people receive that little piece because, to your point, we love our family members and we want them to keep up the good fight and making the effort. And I mean, there is a natural aging biological process that is happening for each of us. So depending on where we are with things, to just honor that is so important. So that comes around to like family dynamics with your family member. And I know this is super sensitive and very nuanced, but just when someone is in rehab and they're making the effort to do the work and get better, where to find family dynamics kind of play in. Like, how can families best support that person? Um, because we all have different ideas about what could and should be done.
Sure, sure.
So, how do we best support the person who's in rehab?
Yeah, and that, I mean, I think that is very difficult when you have family dynamics of maybe children that are not on the same page or seeing eye to eye to what's going on, with a parent or grandparent or any loved one from that point. And it's really trying to, again, listening to your loved one and what their wishes are, and then leaning on the professionals. They are doing their best in order to meet those needs and goals that your loved one has to get stronger, as well as yours, and trying to put your family stuff kind of aside, because that's not going to help your loved one get stronger or try to meet their goals from that standpoint. um, and there are sometimes some tough conversations that have to happen, but you should, as much as you possibly can, you need to keep those preconceived ideas, as well as your family history, of if there's differing opinions or those sorts of things, you need to set those aside in the sake of your loved one. Because, yes, you may not agree, but you should agree that you both love, everyone loves the person that you're caring for, and they are the ones that should direct their own experience and their own journey.
So good. So, can everybody just come in and talk to any medical person in the building, or is there a point person? How does that get determined?
Sure,
Um,
usually setting something up just because, the nurses, the doctors, the social workers, they're, have lots of things to do on a daily basis, and those are meetings that you can always request, and they'd be more than happy to set something up. In a rehab setting, we try to set those up after somebody's been here for maybe 2 to 3 weeks, where we all sit down with the team and the family members, kind of discuss the progress, discuss what we're seeing. Potentially, if we have, recommendations at that time, we will give those, try to talk length of stay. And that's also in the hospital setting too. You can always
mm,
request to meet with the social worker, meet with the doctor, to try to get your questions answered. Now, they're not going to be able to do it on a daily basis, but if your loved one's has been in the hospital for, a week or more, and you just don't feel like you know what direction and what's happening, absolutely request that. And in a rehab setting, it usually takes the team a week or two to kind of see how somebody's bouncing back from their hospitalization and how they're progressing. So that's why you don't usually have more of a formal meeting up until that point, because we're trying to see how fast somebody's going to rehab and how they're doing.
okay. Okay. And there tends to be a power of attorney involved, or some,
Sometimes, not always.
not all.
Yep, definitely. We encourage everybody to have a power of attorney, living will, those sorts of things in a rehab setting. We can help you with those things. If you're admitting to us and you already have those documents, we usually request those, so we have them on our file as well. And then, of course, we ask. When somebody's admitting, like, who's the point person, of your family members, because we usually can't, again, we can't call every family member. And so we really rely on making one contact or one point person, and then that person kind of providing the information to everybody else.
Perfect. This has been so helpful. So, anything else that you can think of about setting someone up for success for a rehab stay? Anything that we haven't talked about, or I'm missing, or just how can they be successful?
Sure. I think, a lot of it is, um, expectations too of if your loved one was struggling before the hospitalization and there were things that you were seeing, rehab may help with that, but it also, may not too. So just knowing and being aware of things prior to, we try to be miracle workers as much as possible. But if somebody was having some, if you were concerned about your loved ones, getting confused before their hospitalization, and then all of a sudden they have a fall and go to the hospital, yeah, like, we may be able to help, get them physically strong and being, walking again. But that cognitive piece definitely may still be there,
Mm,
just the trauma of the fall and hospitalization. Things may be even a little worse now. And, dementia is it's a hard predictor. Some people are able to bounce back a little bit from that, but some people it's, kind of they've then lost that a little bit more ability from that standpoint. So it's ever changing and evolving, and just
yeah.
kind of, yeah.
Well, and I'm thinking anesthesia. I know that sometimes if somebody had to have had a surgery and they had anesthesia, and then they come to rehab, like there's potential that that anesthesia is still working out of their system
Absolutely.
as well, which is just another thing to note. So
Absolutely.
I think this has been great. I think this is a lot of really good information. It feels a little bit like a fire hose, but I'll try and organize the show notes so that we hit the high points. But I'm very, very, very grateful to you for coming on. Thank you.
Thank you so much for having me.
Yeah. Bye.
Bye-bye.